It's great to see everyone. I love graduate students, probably because I feel like I was a graduate student myself for half my life, or at least half of my adulthood. And I actually did my entire PhD online back before it was cool to do that, to do distance learning. So it's great to see that distance learning is becoming a lot more mainstream. I'm going to call this slide deck DBT Basics and Beyond. It's a little bit misleading because in 3 hours, we're not going to get to the beyond part. We are only going to be able to cover some of the few key basics of DBT. Normally when I do these trainings, they are for multiple days, not multiple hours. So I do DBT trainings that are 2 days long, 3 days, sometimes 4 days. And usually when I do a DBT training, it's live in person on site with lots of real-time interaction. So I know we're gonna lose some of that, but I really do want you guys to participate as we go through. So at any time, please feel free to interrupt me mid-sentence. Just shout out a question or a comment. Because trust me, I don't want to stare at the screen and hear myself talk for 3 hours straight. So I gladly welcome any interaction. Okay. Here's my contact information. I absolutely love to network. So if you want to follow up with me after the training itself, by all means, please feel free to do that. Just by way of quick introduction, I am a clinical psychologist, so I contract with the Department of Homeland Security to provide treatment services to asylum seekers. So it's a job I absolutely love. I get to work with people from all over the world that are seeking asylum in this country. And my goal in this training is to get you guys excited about DBT so that you go on and learn a lot more on your own. So if you do want additional resources after this training, just email me. I'd be more than happy to send you a free e-version of this workbook that was published last year. Okay, so since I'm calling this training DBT Basics and Beyond, just without the beyond part, I do want to start with the absolute basics, including what in the world does DBT even mean? So I'm going to go on a limb and assume most of you know what therapy means. At least I sure hope so, right? That's what the T stands for. I'm going to go on another limb and assume you guys know what behavior means. So that's what the B stands for. But what in the world does dialectical mean? Right? That's not a term we tend to use in normal, everyday, casual English conversation. So I'm just curious, has anyone heard that term before? Does anyone want to take a stab at what that means or what you think it means?
Doesn't that mean to teach?
To teach, okay. So yeah, there's absolutely a didactic component of dialectics for sure. It's related to teaching. So you're definitely on the right track. Can anyone else?
Holding two opposing things to be true at the same time?
Yes, you nailed it. Holding two opposing things to be true at the same time. So dialectics is actually a term and a concept that doesn't even come from psychology, doesn't even come from the mental health field. It's actually a concept that comes out of philosophy. And in philosophy, this term has existed for, well, literally thousands of years. So any philosophy student would recognize this term. It actually goes all the way back to Socrates. He's the one that coined the term dialectics. Even in Greek, that was a new term that he came up with. So we've all heard of Socrates. We've all heard of the Socratic method. Basically, Socrates was famous for getting his students to think about things from different perspectives, simply by asking them lots of questions. And he was so good at this technique that he could get one of his students to start articulating a viewpoint that was completely the opposite of where they started, simply by asking lots of questions. So that's kind of where this idea of dialectics started, right? This idea of learning to look at things from new and unique and different perspectives. So now we're going to fast forward many hundreds of years to this guy named Hegel. So he was a German philosopher. And what he noticed was, it wasn't just Socrates and his students that learned how to be dialectical. What Hegel noticed was really this is how all human knowledge tends to evolve. And if you think about it, Hegel was right. Because what Hegel noticed was, basically we come up with some sort of theory to account for our observations, right? So science is full of all of these different theories. And that theory holds weight until someone else comes along and notices other observations or different data points that don't fit that theory, right? So now what? So now we come up with a different theory, a competing theory, a rival theory. So Hegel called the original paradigm a thesis, and he called that rival paradigm the antithesis. But then ultimately what happens is someone else comes along and someone else basically says, now wait a minute, if we take all of the evidence combined that we're noticing and we just look at it from a slightly different angle, we can account for all of these combined observations with yet another theory. And then basically that third theory that emerges is now the new paradigm. And that new paradigm holds weight until someone else comes along and notices additional observations that don't fit. And this process just repeats itself indefinitely. And if you don't believe me, that human knowledge tends to evolve this way, apparently you've never read a research journal. If you've ever read a research journal, you'll notice that research, even especially scientific research, empirical research contradicts itself all the time. Right, so you'll come across one study that will say, for example, wine is good for you. Then you come across another study 6 months later that says, well, actually wine is bad for you. And you're like, okay, so what is it? Well, then you'll come across, usually some kind of meta-analysis, right? Some study that examines 100 other studies. And usually that meta-analysis will come to the very conclusive decision that, well, actually wine is both good for you and bad for you. It depends on many factors, right? That's dialectics. Well, then Marshall Linehan came along, and what Marshall Linehan realized, it's not just scientists or people in academia that learn to think and process academic dialectically. What Marshall Linehan realized was actually those are the skills you need to navigate a healthy adult life. Right? So if you think about it, every day we use dialectics, even if you've never heard that term before, right? So, just to figure out what to do for lunch, you guys had to use dialectics, right? So do I just grab some fast food really quick? Or do I go to a sit-down restaurant? Or do I bag a lunch? Or do I just skip lunch and catch up on emails? But you guys were probably able to come to a decision really fast in your head, right? You were able to weigh out many different options and arrive at a consensus, a conclusion. But what if you couldn't do that, right? What if you had one thought or one belief and you were just stuck on that? And it didn't matter how many additional life experiences you had or how much new evidence was piling up, right? What if you could not change how you thought? That would be a problem. So basically, Marshall Linehan created this entire model that helps a person restore their lost dialectics, so to speak, or learn to process life dialectically for the first time if they've never been able to do that. So ironically, Karl Marx latched onto the same idea of Hegel and created the system called communism, whereas Marshall Linehan latched onto that same exact idea and created a model for borderline personality disorder. So go figure. In this training, we're going to focus on Marshall Linehan's version of dialectics, if that's okay. We'll save Karl Marx for a different day. So that's a really brief philosophical intro to the model. Anytime you learn a new model of psychotherapy, you always want to get to know a little bit about the philosophical underpinnings of that model. But whenever you learn a new model, you also want to get to know a little bit about the person that created the model. So obviously, we all know that Marshall Linehan is the psychologist that came up with the model of dialectical behavioral therapy. So what I would like to do now is just briefly introduce Marshall Linehan. But how I'm going to do that is by reading a New York Times article that was published in 2011 about Marshall Linehan. And what the article I'm going to read, it is public knowledge. It's been public knowledge since this newspaper article was published. But it's fascinating that Marshall Linehan did not disclose this information until 2011. So after I read this article, maybe we'll unpack that a little bit. But this is what the article says. So Marshall Linehan learned the central tragedy of severe mental illness the hard way, banging her head against the wall of a locked room. Marcia arrived at the Institute of Living on March 9th, 1961 at age 17, and quickly became the sole occupant of the seclusion room on the unit known as Thompson 2 for the most severely ill patients. The staff saw no alternative. The girl attacked herself habitually, burning her wrists with cigarettes, slashing her arms, her legs, and her midsection, using any sharp object she could get her hands on. Okay, I'm just going to pause right there for now. So based on those symptoms I just read, what disorder is that sounding like? Right, all of that self-harm. Anyone want to take a stab at that? What's a pretty common mental health disorder characterized by lots of self-harm?
Looks like we've got some responses in the chat there.
Oh.
Two folks have said borderline personality disorder. April
Yep.
and James did.
Yep, absolutely right. Yeah, that's certainly sounding a lot like borderline personality disorder. The seclusion room, a small cell with a bed, a chair, and a tiny barred window, had no such weapon. Yet her urge to die only deepened. Okay, do you see how this is sounding even more like borderline? Right, not only lots of self-harm, but even this urge to die. So she did the only thing that made any sense to her at the time, banging her head against the wall and later the floor. Soon a local psychiatrist recommended a stay at the Institute of Living. So that's located in Hartford, Connecticut, actually probably 20 minutes from where I grew up, to get to the bottom of the problem. Their doctors gave her a diagnosis of schizophrenia. Okay, so I'm just curious, based on all the symptoms we just read about, that cluster clearly sounds like borderline. So why in the world do you think she was diagnosed with schizophrenia? Does anyone want to take a stab at that one? So if you remember, when did this article take place? Or when did this story take place? 1961.
61. Oh, so it looks like we've got the Dr. Reutter. I don't know if you can see the chat when you're sharing your screen.
I can't.
Yeah, I don't think that's a function in Zoom. But Molly Emma said that they used the schizophrenia diagnosis as a catch-all.
Yep, you're absolutely right. Yeah, so it was 1961. So this was decades before there was any formal recognition of borderline as a diagnosis. So if you think about it, borderline was not recognized as official diagnosis until the DSM-3, which was 1980. Right? So they couldn't make sense of these symptoms. So yeah, you're absolutely right. They basically decided this must be schizophrenia. We don't know what else to call this. So therefore, they dosed her with Thorazine, Librium, and other powerful drugs, as well as hours of Freudian psychoanalysis. And then, this next part is shocking, literally. They strapped her down for electroshock treatments, 14 shocks the first time through and 16 the second, according to her medical records. After all that, nothing changed. And soon enough, the patient was back in seclusion on the locked ward. Okay, so do you get the sense here that they were kind of desperate and grasping for straws and were trying whatever they knew to do, right? I would love to see what that treatment plan looked like, right? We're going to start with psychoanalysis. If that doesn't work, let's switch to ECT. If that doesn't work, let's switch to some powerful psychotropic meds, right? They were just going from one thing to another. A discharge summary dated May 31st, 1963, so that's 2 years later, noted And by the way, this last part I'm going to read is a direct extract from her discharge summary. During 26 months of hospitalization, Ms. Lanahan was, for a considerable part of this time, one of the most disturbed patients in the hospital. Okay, so first of all, I can't imagine ever writing that in someone's discharge summary, right? This was the most disturbed patient I've ever worked with. But furthermore, I also can't imagine being that person, right? But that person was Marsh Lanahan. So now that we know this about Marsh Lanahan, do you feel like this information gives the model of DBT credibility? Or do you feel like it takes away credibility from the model? Just curious if anyone has a thought on that.
My name is April. I think tend to subscribe to sort of a phenomenological standpoint, right? In how I think about theory and how I think about interventions and different approaches. And so for me, knowing, right, that her experience was like, she's had this incredibly profound experience with mental health, mental illness. For me, it lends a lot of credibility to the theory because she's drawing from her experience. And so for me, right, if the client is the expert in the room on, what they perceive, how they experience the world, how they move through the world, for her to have potentially drawn from her experience with mental illness in conceptualizing the theory or conceptualizing the practice of DBT, for me, that lends a lot of credibility there.
Yep, absolutely. I totally 100% agree with you. So it's fascinating that Marsh Lanahan was the first person to develop a model that was actually successful in treating borderline, whereas nobody else had. And now that we know this information about her, that shouldn't come as a surprise, right? It had to be someone that knew the disorder inside and out. But I also completely understand Marsh Lanahan's reluctance in not wanting to disclose her own personal history until as recently as 2011. That might not seem so recent to you guys, but it does to me because, I was already a DBT therapist. I was already doing DBT trainings before I knew that about Marsh Lanahan's personal history. But I think the reason that she was strategic in waiting to disclose that information is because if she had disclosed that too prematurely, that could have worked against perceived credibility of the model. Because as we know, borderline did have and still does, pretty entrenched stigma in the mental health world. So Marsh Lanahan did survive these experiences. She even made it into college, where, no surprise, she studied psychology, went on to get a master's. No surprise, she got her master's in psychology and then went on to get a PhD in psychology and then even became a psychologist herself. And once she became a psychologist, which population do you think just felt very attracted to her? People with borderline symptoms. But back in those days, Marsh Lanahan herself wasn't even using the term borderline, right? That term really didn't exist yet. She just thought she was working with clients that were, highly emotionally dysregulated and chronically suicidal, right? Which they were. But there still wasn't even a clear understanding that there was an entire symptom cluster, an entire personality disorder behind those symptoms. So that's when Marsh Lanahan became what we call a research practitioner, because what she realized was, and when working with this population, was exactly what she had experienced herself when she was a patient, and that is nothing worked, right? Nothing that she had been taught in grad school seemed to be working. So as a research practitioner, not only was she a therapist like you guys will be, but she was also doing copious research on all of her interventions, including the outcomes. You see what worked, what didn't work. And she used all of that information to eventually develop her own model, which is now DBT. So something we can learn about DBT right off the bat is it's an extremely practical model. So what I mean by that is everything that's in DBT is there because it works, right? It has worked, and it's been researched, and that's why it's there. Okay, so Marsh Lanahan is still very active in the mental health field, very busy lady. Believe it or not, she decided to join us this afternoon. Just kidding. But I am going to show you a recording of her. So I just want to show you this really quick. It's about a minute long video clip. And this will give you a really good intro to the model.
You know, I've seen a lot of changes in people who've been at DBT, and it's really almost impossible to describe them because the problems people come with are very different. And our goal is developing lives worth living, and that looks different in different people. My main goal for people who come into therapy is that they get out of hell. That's my first goal. And my second goal is that they stay out of hell. And this is one of the main reasons that we teach skills, because skills are aimed at helping individuals build lives that they themselves will experience as worth living. The idea is that if you can build a life that you experience as worth living, you'll keep living and you'll stay out of hell.
Okay, so like I said, that is a really good, concise 1 minute preview to the entire model. So in that video clip, she basically mentioned the 3 goals of DBT, right? So the first goal is to help clients get out of hell. So by the way, hell is pretty much a technical term in DBT. And what do you think it's referring to? Right, Marcia Linehan has lots of words that she's kind of co-opted in. She kind of imposes her own unique definition on them, and hell is one of them. What do you think she's referring to when she uses the word hell?
I imagine it's likely the extreme emotional dysregulation someone feels, just kind of feeling of being out of control.
Yep, you're absolutely right. She's referring to the excruciating pain that can result from emotional dysregulation. Yeah, so the first goal is to help our clients get out of their personal hell. The second goal, if you remember, is to help them stay out of that hell. But then the third goal, if you remember, is to help our clients build a life worth living. Right? It's not just to get them out of hell and keep them out of hell, right? It's the model culminates in this, this positive psychology type of perspective in which we now help our clients build a life that's personally meaningful to them. And then in that video clip, she also mentions the means by which we accomplish all 3 of those goals. So I don't know if you remember that, but she said it's through skills building, right? So we teach our clients the skills to get out of hell. We teach our clients the skills to stay out of hell. But then we teach our clients the skills to start building a life that's personally meaningful for them. And this exclusive emphasis on skills building is one of the markers that kind of makes DBT unique among models of psychotherapy. Because it's an entire model that's exclusively devoted to simply skills work. And that's also what makes DBT so user-friendly, so to speak, because you can plug it into any other approach that you're using. It doesn't matter what your philosophical orientation is. It doesn't matter which school of thought you're pursuing. It doesn't matter what your preferred modalities are for doing treatment. Regardless of all that, you can certainly add more skills to your toolkit, right? And DBT does that. So that's why DBT is such a versatile model. You can use it with pretty much anything. Oops. Okay, so according to DBT, our clients do have 4 basic options when they seek us out in treatment. These 4 options are delineated in Marcia Linehan's manual. So when a client comes to see us with some kind of presenting problem, one option we have is to teach our clients the skills to solve that problem. But not all problems in life can be solved. So therefore, another option we have when working with our clients is to at least teach them the skills to feel better about that problem. However, it's also not possible to feel better about every single problem. We don't really have to go too far in the news these days to realize that there are certain problems we don't want to feel better about. We shouldn't feel better about. So therefore, another option we have when working with our clients is to teach them the skills to tolerate the problem. Okay, so there's a lot I could say about that. I'll speak a little more to this theme when we get to radical acceptance. So from a DBT perspective, tolerate the problem doesn't mean condone it. It doesn't mean we'll let it slide. It doesn't mean, well, it is what it is. It's simply having the skills to be able to contain our emotional energy in response to the problem so that we then can deal with it. But our clients actually do have another option when they present, and that is they can choose to stay miserable, right? And that's an option we can't forget about, because sometimes with some issues, some of our clients do choose that. So just realize that DBT is all about those first three options, right? The good news is we don't have to teach clients to stay miserable. Some of our clients already know that. But the bad news is sometimes that is an option that our clients pursue, right? And we can't be naive about that. Okay, so there's a way to understand DBT as a model if we don't first have a thorough understanding of borderline personality disorder. And normally when I do these trainings, we talk a lot about borderline. But basically, all I'm going to say here is borderline is basically a disorder of complete chaos. Chaos of emotions, chaos in beliefs, chaos in relationships, chaos in the environment, chaos in self-image. We can just go on and on and on with all of them. Which kind of begs the question, so where does all of that chaos come from? So Marshall Linehan developed this biosocial model to explain the etiology of borderline. So obviously, this idea of both biological and environmental influences is not unique to DBT or borderline whatsoever, right? You could apply this to any disorder. But what Marshall Linehan realized was borderline has specific biological and specific environmental influences, which end up causing borderline symptoms. Once again, we could talk a lot about this slide, but for now, I just want to point out that borderline does seem to have some specific biological influences. So one of those is temperament. And there's a few ways that temperament can play a role. Sometimes some kids just have a very super sensitive temperament. Sometimes some kids just have a high maintenance temperament. And sometimes some kids have a temperament that is completely different than everyone else in that family constellation. So those are the three temperaments that are most vulnerable to developing borderline. And then another basic biological factor is something as simple as sex. So when I'm using the term sex, I'm referring to just raw biology, right? So XX chromosome versus XY chromosome. So I'll probably swing back to that topic of sex in a little bit. But so we could talk a lot more about biological influences. I'm just going to use two just for the sake of simplicity here. But then what Marshall Linehan noticed was it's not just biology. Environment plays a huge role in the development of borderline symptoms. And if you take all of the environmental factors combined, what Marshall Linehan noticed was they all boil down to one single theme, which Marshall Linehan identified as invalidation. So this is a really important term. So I want to make sure we have a good understanding of this concept. Does anyone want to take a stab at defining what we mean by invalidation? So feel free to either send a message on chat or just speak up. So does anyone have a working definition or some practical concrete examples you can think of?
This is April. I'm thinking just about like dismissal or kind of undermining where someone is coming from. Dismissal, I think, really comes to mind for me.
Yep, no, you're absolutely right. So invalidation is basically any time we somehow dismiss or discount someone else's experience, right? Could be their emotional experience, their cognitive experience, their whatever. So invalidation can include many things, right? It could be as simple as saying, well, that didn't hurt when it did. And I'm not trying to suggest that you make a comment like that one time to one kid and now they're doomed to a lifetime borderline. I'm not suggesting that at all. But do you think it's possible to receive enough of those kind of messages over and over and over again, such that someone really does develop full-fledged borderline, even if they were never overtly abused or traumatized? Do you think that's possible? And the answer is yes, right? If you have the right temperament, right, sensitive temperament especially, and you receive enough of that kind of invalidation, you can develop full-fledged borderline. That's possible. You might even meet some adults who have full-fledged borderline that will tell you, I was never abused, was never neglected, never traumatized that I can think of. But what we now know is all of those instances of invalidation have a cumulative effect that are traumatizing. So something else that Marshall Linehan noticed was it's not just biology and it's not just the environment. It's actually how those two feed off of each other and kind of create this, sometimes this vortex, this, this negative spiral effect. So it's really how they both feed off of each other, right? She called that the transaction between nature and nurture. So let me just give you some examples of what I mean by that. So for example, if you have a very sensitive temperament, right, that's biologically programmed into you. But if you have a sensitive temperament, you will be more likely to perceive and maybe over-perceive invalidation, right? Or if you have a high maintenance temperament, you are going to be more likely to elicit invalidation from other people, right? Or if you have a temperament that's completely different from everyone else in your family structure, you will feel invalidated inherently, right? So you see how it's not just raw biological programming, it's how that programming interacts with the environment and how the environment can actually trigger that wiring. So, when I was talking about nature, I used the term sex, but we can also use the term gender, which refers to the whole, spectrum of masculinity and femininity. So which of the two genders do you think tends to be more invalidated, right? Male or female?
Female.
Yeah, female. So once again, it's not just a matter of raw biology. It's more a matter of how biology interacts with environment, how environment interacts with biology. So is that to say that a male growing up in a highly invalidating environment is somehow exempt from pathology and they're just more resilient, they're tougher, and they're fine as adults? Or does their pathology tend to take a different trajectory? Any thoughts on that? So whereas a female growing up in a highly invalidating environment will be more likely to develop borderline symptoms, a male growing up in that same environment still might develop borderline, or they might develop, say, antisocial personality disorder, right? Or narcissistic personality disorder, right? So males are not exempt. Their pathology just tends to take a different path, right? And we could debate all day long on why that is. So, on a biological level, is there a difference between XX chromosome versus XY? Well, of course there is, right? You factor in testosterone and you will many times have a different result. But is there also a difference in how we're socialized? Well, of course there is, right? That's also just as true. So whereas females probably tend to be overdiagnosed with borderline, you could also make the case that males tend to be underdiagnosed. Okay, yeah, so there's a lot more we can say about this, but the main takeaway from this slide is the insight that Marshall and Han reached, and that is it's mostly invalidation that's driving this boat. And that is really important information to have, because if we know that invalidation is mostly what causes borderline, right now we have a starting point to know how to treat it, right? And I just want you to think about everything going on in the news, current events. Just think about what an invalidating culture we live in, right? So think about it. Validation doesn't just come from family of origin, right? That was kind of Marshall Linehan's focus. But just think of all of the invalidation that happens at the political level, in social media, and we could go on and on. Okay, so people that have, the right temperament and lots of invalidation are vulnerable to what Marshall Linehan called emotional vulnerability. And this is what she described this is how she basically defined emotional vulnerability. Basically, when someone has more negative emotions at baseline than the average person. So more anxiety, more anger, more depression, right? To use a Freudian term, basically just more neurotic. And in addition, also more sensitive. And in particular, more easily triggered by things that would not be triggering to other people. And when they are triggered, their emotions reach a much higher intensity, right? They spike at higher levels. And because their emotions are spiking at higher levels, they also take longer to return to baseline. So another quick point I want to make on this slide is that, this biosocial model does not help us predict with, exact scientific precision who will or will not develop borderline. But what it does do is it helps us identify the risk factors, right? So for example, and actually, let me just back up a moment. What do you think is probably the worst form, one of the worst forms, if not the worst form of validation possible, right? Especially for a kid?
Mixed messages.
Yeah, mixed messages certainly are. And one of
yes and then saying no.
What's that?
Like saying yes and then saying no, so they start to not trust themselves. They don't know like what to believe.
Yeah, all like double binds, anything that's crazy making for sure. And if you think about it, probably the most confusing mixed message of all is sexual abuse. So in my opinion, and there's research to back this up, in my opinion, sexual abuse is probably the most invalidating thing you can do to a child, because it basically sends the message that nothing about you matters, right? You don't matter emotionally, you don't matter mentally, you don't matter physically, you don't matter sexually, you don't matter spiritually, right? All in the process, also sending all these mixed messages, right? You are my special one, and therefore I'm hurting you, right? I mean, a child cannot reconcile those kind of mixed messages. So do you see where this breakdown of dialectics comes from? Right? It's difficult enough for adults to reconcile contradictions. Kids do not have the cognitive capacity yet to do that. So, so once again, back to my earlier point, and that is, that we can't use this model to predict exactly who will develop borderline or not, but it does help us identify the risk factors. So for example, if you have a sensitive temperament that's also high maintenance, that's also an outlier, and you're a female, and you've been sexually abused, you are now on the fast track towards developing borderline. So does that mean you will develop it with absolute certainty? No, it just means you are certainly at risk. So some people will develop borderline with maybe just a few or a couple of those risk factors. There might be someone that has all of those risk factors and doesn't, right? Because of other resiliency factors they bring to the table. But regardless, this helps us understand who is most at risk. Okay, and the right risk factors in combination with lots of invalidation will culminate in this emotional vulnerability. So what Marshall Linehan noticed as she was working with this population was that this emotional vulnerability was also correlated with other problems. So one of the deficits that she noticed was that her clients had just a really basic lack of awareness. So starting with self-awareness, right? Awareness of their own bodies and their own emotions and their own thoughts. And if you're not terribly aware of all of that, then you're also not going to be aware of what's going on in your relationships or your environment, right? That lack of awareness just kind of spreads. And then another deficit area that Marshall Linehan noticed in connection with emotional vulnerability was highly polarized thought patterns, right? So if you're coming from a CBT background, you might think of black and white thinking or binary thinking, right? Or dichotomous thinking, right? Everything is either this way or that way. And if you think about it, that makes complete sense in light of the invalidation they came from. Not only were they receiving lots of mixed messages, but they also had to learn early on who is good and who is not, right? Just have two basic categories for people, right? Either one category or the other, right? So very much survival type thinking. But then that type of thought process becomes generalized to everything else in life, right? Everything is either this way or that way. And they're missing out on the whole spectrum of that gray area in between. So someone that is emotionally vulnerable, obviously they will also have unstable emotions. So lots of mood swings up and down and all around. But something else that Marshall Linehan noticed with this population was very maladaptive coping strategies. So not only was this population very easily triggered by experiences that other people wouldn't consider to be triggering, but then their ways of coping with those incidents made things even worse, not better. So that's kind of what I mean by maladaptive coping. And then something else that Marshall Linehan noticed, as a result of all these other deficits, they just really struggled to understand relationships or make relationships work, right? Really struggled to understand what makes people tick or ticked off for that matter. So if you think about it, these 5 deficits are a really good summary of borderline personality disorder. Right? If you've ever studied the DSM-5 symptoms of borderline, you'll notice examples from each of these points. Right? This lack of awareness, polarized thinking, emotional instability, maladaptive coping, and lack of people skills. So once again, I wish we had time to unpack that a lot more. But just brush up on your DSM-5 symptoms of borderline and you'll know exactly what I'm talking about. This is a really good 5-point summary of those symptoms. So based on those deficits, Marshall Linehan did something that was extremely practical, right? Since her clients lacked in those areas, what she decided to do was teach them skills in each of those areas. So if you think about it, let's actually just go back to this slide briefly. If you think about it, one of the main reasons that Marshall Linehan decided to devote an entire model to skills work is because if you have these deficit areas, guess what? You don't even have the skills to do counseling, much less anything else in life, right? You think about it, traditional talk therapy requires that you have some level of functionality in these areas, right? At least something as a baseline to build off of. If you're working with a client that has absolutely no self-awareness, well, the whole point of psychotherapy is to foster insight. What if they don't even have enough self-awareness to start with? Or, the whole point of talk therapy is to help teach our clients to reframe life experiences. What if their thought processes are so polarized that the only frames you have to work with are extreme A and extreme B? That's not going to work. What if your client is so emotionally reactive that no matter what you talk about, they either shut down, dissociate, or they just leave in a rage? If you haven't had that experience yet, you will someday, trust me. You'll have a session in which within 5 minutes, the client is already storming out and slamming the door behind them with a few choice obscenities, just in case you didn't get the point. And you're like, what the world? We didn't even talk about anything yet. What just happened? Right? So you can't even do traditional counseling if you are that emotionally unstable. Or if you think about it, traditional talk therapy is all about dealing with topics that are triggering. What if your coping is so maladaptive that you can't even handle the topics that need to be addressed in counseling? Or if you think about it, something we all know, regardless of what model regardless of what orientation you espouse, what is the most important key active ingredient in all psychotherapy? Right? It's the therapeutic alliance. What if you don't even have the people skills to develop a relationship with your therapist? Right? So that's why Marshall Linehan decided, you know what? I'm going to develop an entire model devoted to skills, because my clients can't even do counseling until they first learn these skills. And that's how we end up with these. And do you see how these skill sets, each of these are a match to the deficit area, right? So for example, if my client doesn't have basic awareness, I will teach them this great skill called mindfulness. So was Marshall Linehan the one that invented the term or concept or discipline of mindfulness? Obviously not. So where is she getting this from, right? I'm sure you already know the answer to that. Mindfulness comes mostly from Eastern spiritual traditions. So every spiritual tradition has some kind of mindfulness practice, but this is a skill that's been honed for thousands of years in Eastern cultures. So what Marshall Linehan realized was, wow, this is a perfect skill set for what my clients need. So she just basically co-opted that entire concept of mindfulness and brought it into DBT. Remember, the second deficit area was this polarized thinking, right? Thinking at the extremes. So that's when Marshall Linehan realized, oh, there's another really, really good concept out there called dialectical thinking, which is all about learning to live with your opposites and even maybe come up with a novel solution in the middle, right? Once we can embrace your opposites, what that also does is it frees us up to start looking at things from new and fresh perspectives, right? So did Marshall Linehan come up with this idea of dialectical thinking? Of course not. As we've already established, that comes from Greek philosophy. So what I want you to notice so far is Marshall Linehan is all over the map here, right? She's getting mindfulness from Eastern spiritual traditions. She's getting dialectical thinking from Western philosophy, right? Those are two traditions that have nothing to do with each other. But kind of the genius of Marshall Linehan was her ability to cherry pick from very different traditions and pick and select something that would be useful in the treatment of borderline. And that's exactly what she did. So emotion regulation, and that's pretty self-explanatory. But if you think about it, traditional talk therapy really didn't do much with that, right? Think of, especially like CBT, cognitive behavioral therapy. Well, you have cognitive, you have thoughts addressed, you have behaviors that's addressed. What about emotions? Right? So even though CBT has this idea of thoughts lead to emotions, which lead to behaviors, the model is called cognitive behavior, right? So emotions weren't given a ton of attention in the history of psychotherapy. Marshall Linehan realized, well, we're gonna have to change that. Distress tolerance is obviously all about dealing with triggers and stressors in an effective way. And then interpersonal effectiveness is obviously all about teaching clients basic social skills, communication skills, conflict management skills, etc. Now, one of the drawbacks of DBT, I'll just be honest, is that it's kind of loaded with lots of jargon, right? Lots of words that roll off our tongues pretty easily, right? As graduate trained clinicians, but not necessarily terminology that our clients use. So one of the things I highly recommend when you use DBT with a real client is you figure out your own phraseology. And better yet, you figure out phraseology that makes sense to your client. So I realize that mindfulness is becoming more of a mainstream word in Western, in English. It's actually still hard to translate into other Western languages, right? And it's really hard to say this in Spanish, for example. There's no word. A lot of times they just say mindfulness. They just steal the word. So we can't assume that all of our clients are using mindfulness as a term on a daily basis. Chances are they're not. So therefore, you might have to come up with alternative ways of saying that. So you might simply say, we're going to talk about how to stay grounded in the present, or we're going to learn how to focus on the here and now, or we're going to learn to be more aware and accepting, right? So you might have to use alternate phraseologies. Same thing definitely applies to dialectical thinking, right? I've never heard a normal person use the word dialectical thinking in a normal sentence. The only time I've ever heard that phrase is when I was talking to either a philosophy student or someone that was trained in DBT. So once again, you might have to say things like, we're going to learn how to be more balanced with our thinking, or we're going to learn skills about being more flexible with how we think, or we're going to learn how to think more in the middle and not at the extremes. Emotion regulation, once again, that might be a little more straightforward. I've worked with adolescents, however, that did not understand the word regulation. And actually, I'll just make another quick point here. Another critique I have with the wording is a lot of times people, including prominent DBT therapists, will use the phrase controlling emotions as synonymous with emotion regulation. And I'll admit that makes me cringe, because we're not teaching our clients to control their emotions, right? If you think about it, that's actually hearkening back to the invalidation they received. We're teaching our clients, yes, maybe to manage their emotions, but even more importantly, to care for their emotions, to cultivate their emotions, not control them. So once again, if you're going to use a paraphrase, just be careful what kind of a paraphrase you're using. Distress tolerance also tends to be more academic sounding than it needs to be for your typical client. So instead, you might say something like stress management, or even simpler yet, coping skills. Right? That's all distress tolerance is. And then, if you think about it, this last one is the kicker here, because just think about it. Interpersonal effectiveness. Okay, that was 9 syllables. Okay, that's obnoxious. Most English speakers do not walk around using 9 syllables to say a simple term. So once again, you can use all of the paraphrases that I used earlier, right? People skills, social skills, communication skills, conflict skills, etc. Okay, what we don't want to do is intimidate our clients with a lot of jargon that makes sense to us, but might be inaccessible to them. Okay, so what I want to do now is briefly talk about kind of the evolution that DBT has experienced. So the first manual that Marshall Linehan produced in the early 90s, and by the way, this was the manual that I used to learn DBT. So it's pretty fascinating if you just look at that title, right? So she's calling it Cognitive Behavioral Treatment of Borderline Personality Disorder. And, that's kind of where mostly that is where DBT started. But here's what's fascinating. Because Marshall Linehan basically took CBT skills and concepts, but she also learned right away that CBT as it existed at the time was not going to cut it. So she started to modify it and customize it and tailor it into something different. But what's really interesting is Marshall Linehan herself was calling her model DBT when she produced this manual. So why do you think she's not just calling it DBT? Why is she calling it basically CBT for borderline? Does anyone have a thought on that?
Our field is pretty rigid with bringing in new ideas, and so I'm guessing she wanted to latch on to an existing, widely accepted therapy to try to get some traction.
Yeah, absolutely right. So at the time, and still, CBT had lots of really good credibility, right? Lots of good, street recognition, so to speak. Lots of really good, solid research, decades of research. DBT in contrast was kind of like the new kid on the block. And so, yeah, it was a convenient, strategic way for the model to get some traction, right? We'll just call it CBT for borderline. even though she clearly was bringing stuff well outside the scope of CBT, right? You know, for example, mindfulness itself. So this is what she's originally calling that first manual. But then it's really interesting to see the evolution that took place. So more recently, so within the last 5 years or so, she produced this manual. And it's a complete, not just a facelift here, it's a complete paradigm shift, really, because now she's calling it DBT Skills Training Manual. It's a completely different title. So what changed? Well, one thing that changed is obviously she's now calling it DBT. Because by now, DBT was no longer the new kid on the block, and DBT was now enjoying its own decades of research supporting this approach. But if you notice, she completely drops the reference to borderline. That's pretty interesting, right? Because DBT originally started as a model to treat borderline. And it's by the way, it's still the gold standard in treating borderline. No other model has come along that's more effective specifically in treating borderline. But here's what the research showed as it came in, that DBT was also effective in treating other disorders besides borderline. If you think about it, that should not be a surprise whatsoever. Because if you can come up with a model to treat borderline personality disorder, trust me, you can treat just about anything. And not only that, if you think about all the symptoms of borderline, there's like symptoms of at least a half a dozen disorders that are part of the package of borderline, right? So when you're treating borderline, you're actually treating, kid you not, a half a dozen different disorders at once. So she drops the reference to borderline, but she also, instead of calling this treatment, she's now calling it skills training. And I like that. I like that shift, because if you think about it, just teaching people skills, sometimes that is the treatment, all the treatment people need. But for a lot of our clients, especially think of complex trauma, the skills work is simply the beginning, right? They need these skills in order to do lots of the heavy lifting that they'll have to do with trauma work. And once again, this speaks to how we can use DBT with no matter what your approach is, right? Because it's simply skills training for them to do further work with whatever your model calls for. And then she highlights this change. She's now calling it a manual. In the first one, she didn't. So that's kind of another indication of how the model has evolved. Over time, the model has become more manualized. And there's a lot I could say about that, both pros and cons, but regardless, the DBT model is now manualized in the sense that in the sense of following certain protocols and adhering to what Marshall and Hand has spelled out specifically in her manual. Okay, so we've seen the evolution of DBT from a CBT spinoff into its own model, which kind of begs the question, so what is DBT? Like, is it still CBT or is it not? And it really depends on how you define CBT. If you define CBT as Aaron Beck's original model, then no, that's not DBT. DBT has evolved it certainly borrows from that original CBT model, but it's also expanded and evolved in many other directions. However, I think most of us nowadays do not define CBT narrowly as Aaron Beck's original model. I think most of us nowadays see CBT as an entire family of models that focus primarily on thoughts and behaviors. And if you think about it, there's many CBT type of models out there, right? And we all kind of see them as fitting under this broad CBT umbrella. So if you define CBT that way, then DBT is absolutely part of that CBT family, right? It's part of that CBT tradition. But what makes DBT unique is within that family is how it deals with thoughts and behaviors, right? So, DBT, you can still conceptualize it as CBT in that it focuses on cognitive components, but how it does it is very different. So if you think about, the original CBT way of dealing with problematic beliefs is basically through confronting, through challenging, through correcting, right? Through pointing out how your thought process is irrational, it's illogical, there's no evidence for it, doesn't make sense. Okay, so I know I'm being a little bit facetious here, and that approach clearly has worked for millions, for lots and lots of people. But do you see how that's not going to work for someone with borderline? And why not? Remember, what causes borderline in the first place?
Invalidation.
Invalidation. So do you see how this original CBT way of dealing with problem thoughts isn't going to work? Because that's going to come across as much too invalidating. So DBT recognizes the need to help our clients have, a healthier cognitive landscape, so to speak, but it does it in a completely different way. It does it through mindfulness training and through dialectical thinking. DBT also focuses on behavioral components, but it's also doing this through a much different lens than original CBT, right? Whereas original CBT originally came from behaviorism, which was all about learning new behaviors through either consequences or associations, right? DBT is going to accomplish that through skills work. So distress tolerance, once again, is all about teaching clients better coping skills. Interpersonal effectiveness is all about teaching clients better people skills. But once again, the way in which DBT is also unique is its emphasis on emotions, emotion regulation. If you notice, I put emotion regulation in this chart right next to dialectical thinking. And the reason for that is because in DBT, our thoughts and our emotions are both equally valid. Okay, that is a departure from original CBT. CBT actually corresponds very well with the bias in our Western culture in which we give more priority to our thoughts than our emotions, right? That's a bias of our culture. So it's no wonder that CBT took off in the US. Trust me, CBT did not take off the same way in other parts of the world as it did here, because other cultures don't share that bias that our thoughts are more important than our emotions. DBT corrects that bias. What DBT realizes is, no, our emotions are just as much as important as our thoughts. Both need to be channeled and regulated for sure, but they're both equally important, right? So go back to the original CBT conceptualization of thoughts lead to feelings, which lead to behaviors, right? But by calling the model CBT, right, cognitive behavioral therapy, well, what happens to emotions? Emotions are basically, from a CBT perspective, the annoying side effect of however you think and the trigger for your behaviors, right? It's just this nuisance in the middle that we need to somehow deal with. That is not the DBT perspective. DBT perspective is our emotions also communicate very important information, right? Just like our thinking mind communicates with words, our feeling mind communicates non-verbally, which is actually even more amazing. And what we know now about how the brain works is the prefrontal cortex, the thinking part of our brain, is actually only a small part of our brain. The rest of our brain is basically summarizing everything that's going on in our bodies and very succinctly produces an emotion to summarize everything that's going on in our body. And that those emotions communicate to us non-verbally. And what we also have learned about how the brain and body works is the brain actually does much more bottom-up processing than top-down processing. So in other words, CBT has this idea of thoughts lead to feelings. Well, what brain science shows us is actually feelings lead to thoughts much more than thoughts lead to feelings. So those are all ways in which DBT has borrowed from the CBT tradition, but also corrected it, I would say. Sometimes you'll hear this term, third wave behaviorism. So what in the world does that mean? Well, basically, CBT has been on this trajectory. We didn't start off with CBT. We started off with just behaviorism. So once again, that's, think of learning through either consequences or association, right? So operant conditioning or classical conditioning. So that was a major thrust in psychotherapy for a long time. But then clinicians and researchers started to realize, okay, we're not just pigeons, we're not just lab rats. We also have beliefs which influence our behaviors. So it's not just a matter of consequences and associations. So that's when we had CBT. But then what psychotherapy has realized is the best way to change our emotions and our thoughts and our behaviors is actually through mindfulness training. So DBT fits in this third wave of behaviorism, where it's basically CBT plus mindfulness. Okay, so remember, I mentioned earlier that borderline basically happens when there's a breakdown in dialectics, right? This breakdown in inability to see and process the world dialectically, to bring together opposites. And there's many dialectics that DBT addresses. But for now, we're only going to talk about one. This is the key dialectic of all DBT. So going back to Marsha Linehan, what she realized when she was working with this population of people that were highly emotionally dysregulated was, on one hand, they needed to be desperately accepted for exactly who they were, just unconditionally accepted. Why is that? Well, just think of their history of chronic invalidation, right? Treatment was not going to work unless they felt completely accepted. But then on the other hand, Marshall and Han realized, okay, so this population also needs to drastically change, like immediately and yesterday. Why is that? Well, because they were constantly suicidal, and their ways of coping were making things even worse, right? They're in hell. They need to change. So the dilemma Marshall and Han faced was, well, they need both. So now what do I do? And to further reinforce this dilemma, if you think about it, when Marshall and Han would have been a grad student like you guys, there were two competing schools of thought at the time. On one hand, there was unconditional positive regard. Where's that coming from? Right? Carl Rogers, right? Person-centered therapy. But then on the other hand, there was just raw behaviorism, right? Think B.F. Skinner. Think of reinforcement schedules, punishment and positive punishment, negative punishment, positive reinforcement, negative reinforcement, all of that. Those were her two paradigms, right? Either just accept the client or try to change them through all of these mechanistic methods. And what she realized was, well, my clients actually need both. So do you see how this is a dialectic? Do you see how we have two competing needs here? But do you also see how these competing needs can both be true at the same time? So in fact, when you can accept someone unconditionally, you've already provided the first conditions to change, right? And what do you need in order to change a problem? Well, you first need to accept that it's a problem, right? So it's not like these two concepts are mutually exclusive. Think of them more as two sides of the same coin. But having said that, is there always going to be this nice, neat balance or harmony between these two competing needs? No. This is messy business. And DBT doesn't tell you, it doesn't give you any kind of algorithm to figure out, okay, how much acceptance versus change does my client need in this moment? This is a balance that is in constant flux. And so the art of DBT is you as the therapist, you use your own clinical judgment and expertise and competence and experience to figure out for any given client, any given situation, how much acceptance is called for right now versus how much change. So this is kind of the mother of all of the different dialectics that you'll see embedded throughout DBT. Right? The DBT therapist is constantly striving for this balance. But fortunately, the model itself lends itself to this balance. So if you think about it, two of the skill sets that we've talked about are all about acceptance, mindfulness and distress tolerance. With those two skill sets, you're not helping a client change anything. You're actually helping them embrace the reality they have in this moment. But then there are change skills. So emotion regulation and interpersonal effectiveness are all about helping a client create a brand new lifestyle that will be conducive to healthier emotionality and conducive to healthier relationships. And then what does it take to bring together opposites, right? That takes dialectical thinking. Okay, so not surprisingly, the most important skill that we need to learn as therapists, if we're going to be working with people with borderline symptoms, is to learn how to be really good validators, right? There's no way around it. And the reason that this is also so important is because precisely since DBT is a model of skills training and skills work, we can easily become too mechanistic and forget that, well, actually half the equation is not helping them change, but just accepting them, right? Going back to that, that balance. So even though the model focuses on skills work, we cannot forget that the most important ingredient is still our relationship with them. So Marshall Linehan lays out these 6 different levels of validation. And these 6 different levels are sort of like a hierarchy in the sense that a higher level also includes all prior levels, right? They kind of build on each other. But this is not a hierarchy in the sense that a higher level is better or superior. That's not the case. It's up to us as the therapist to figure out which level of validation will best address the client's need. Sometimes the most validating thing we can do for a client is simply be present and mindful, right? I've had entire sessions, right, especially if we were processing the recent death of a loved one, in which I hardly said anything. And I certainly was not providing any clinical interventions besides being present and mindful. That's what the client needed to be regrounded and recentered, right? So just because that's the one doesn't mean that's inferior to something else. No, it just means it's foundational. But sometimes when we're present and mindful, we realize that additional layers of mindfulness can also be helpful. Additional layers of validation will also be helpful. So that's when we add on additional levels. So one way of doing that is to reflect back what the client is telling us, both verbally and non-verbally, right? You can reflect back verbal communication through, active listening or paraphrasing or asking clarifying questions or summarizing, right? You've learned all of these techniques. But it's also important to reflect back their nonverbal cues. And actually, we can do a lot of that without even the client knowing it. So if the client starts to accelerate their speech, maybe that's your cue to also speak just a little faster. Or if they speak more softly, maybe that's your cue to lower your own volume, just slightly. And the reason for that is if we can mirror back some of their nonverbal cues, that will register at a deeply subconscious level as extremely validating. Why is that? When we think about it, mirroring is what we do to a newborn baby just instinctively, right? If the baby smiles, what do? We smile back. If the baby says gobbledygook, what do? We say gobbledygook right back. No one thinks that's strange, right? We just instinctively mirror babies, and that's their first experience with validation, and it's critically important. So if our clients have a history of chronic invalidation, chances are they missed out on basic mirroring. So you can do that right in session. So obviously there's a difference between mirroring versus mimicking, right? We're not mimicking our clients, but we can mirror them. Another way of reflecting back both verbal and nonverbal communication at the same time is when we point out discrepancies in the two, right? Sometimes our clients will say something with their words, but their body language is saying something completely different. So what you can do is you can show that you're not only attuned to what they're saying, you're also attuned to what their body is saying without words. So you can say something like, okay, you said X, Y, and Z with your words, but your body language and your facial expressions seem to be telling me something else. And I want to make sure I'm tracking with both, because both are important messages, right? So can we talk a little bit more about what your body language is telling me? And that's actually a way of showing that you're really paying attention to them. Another layer of validation that we can add to the mix is not just reflect what they're saying, but normalize it. So we can say things like, oh, it makes sense that, right? And we can normalize something that happened to them previously or normalize something that's going on right now. So we can say things like, yeah, it makes sense that you don't want to just jump right back into a dating relationship, right? Just look at how the last 3 have gone, right? So in that simple sentence I just used as an example, do you see how I normalized both the history and what's going on right now? Okay, and then finally, the last layer of validation is what Marshall Linehan calls radical genuineness. So this is when we are just real with our clients, person to person, not even necessarily therapist to client. So are we going to be radically genuine with every single one of our clients all the time? No, because our clients can't necessarily handle that much authenticity all the time, right? This has to be done in small doses and when they're ready for it. And if you think about it, that's why this is last, because you can't possibly be radically genuine if you're not also validating in all of these other ways. So what if you have enough rapport with your client to pull this off, by all means do it, because when you're real with a client, that's going to strengthen your therapeutic alliance even more, right? Because they're going to have even more trust in you. So to me, it's absolutely fascinating that Marshall Linehan did not call the highest level of validation unconditional positive regard, like Carl Rogers would have, even though Marshall Linehan clearly had a high regard for Carl Rogers. She's calling it radical genuineness. I want you to think about that. Why is that the most validating thing of all? We don't have time for a long philosophical discussion on this, but just think about it this way. If I am only unconditionally positive, but my client is in hell, am I necessarily validating their experience? Right? Do you see how radical genuineness is actually a better way to validate? Does anyone have any reactions to what I just said? Or do you need some practical examples?
Can you do the last, can you give an example of number 6?
Yeah. Okay. So yeah, I'll give an example of a client I had. So a real client. Okay. So she was chronically molested as a child by many different people. As an adult, she was very high functioning. She was married with 4 kids that were adopted from 3 different countries. She was a physician's assistant, and she was actually going back to school to become a counselor. So very high functioning, but still had some borderline symptoms. And I remember in one session, she was lamenting to me about how she just felt like she was an awful parent because she was yelling at her kids too much. And my first instinct was to be unconditionally positively regarding. So I just basically unleashed this whole litany of compliments, all of which were completely true, by the way. But I started saying things like, what are you even talking about? You are one of the best parents I know. Like, what parent out there adopts 4 different kids from 3 different countries, but in addition to that, you're a physician's assistant and you're becoming a counselor? Like, you have the most amazing skill set ever to be a really good parent. But what I noticed was the more I went on and on with my unconditional positive regard, the more she actually started to shut down. Why is that? Because I wasn't listening to her pain. She felt awful because she was yelling at her kids too much, and I was dismissing her reality. Right? So I know Carl Rogers would say, well, you weren't truly unconditionally being positively regarded, which that's true. But what if instead of doing all that, I had simply said, you know what, I get it. When I am too stressed out, I do the same thing. and I also feel awful when I yell at my kids. Okay, do you see how that would have been real, person to person, and not me trying to be unconditionally positive?
Oh my gosh. Yes.
So the radical genuineness can actually be more validating.
Yeah. It makes me think of what's kind of going on, because I have a client where I'm trying to use these skills, and what's going on right now with just she asked me about like, how are you feeling, because we were kind of touching base about just like racial injustices, blah blah blah, what's going on in society. And instead of, it's like me being real with her and kind of mocking that parallel process of we're feeling similar things, having a similar reaction and experience. I feel like humanized me, normalized her feelings, and she felt like it was real versus like everything's going to be okay, or just instantly starts talking about positive coping. It was almost like we both were like, this sucks. Let's sit in this, let's discuss it. And it sucks for me too. So I didn't know it was called that term, but yeah.
Yeah. So another way of thinking about it is, sometimes when we say, yeah, I can totally relate to what you're going through, and we can't, that's actually highly invalidating. And a client will pick up on that insincerity. Sometimes the most validating thing we can say, ironically, is, wow, I can't even imagine what you're going through. I can't even relate to that. I remember when I was in counseling myself, so I was a grad student at the time, the most validating message I heard from my counselor was when he said, wow, Kirby, I cannot even relate to this. Right? That's when I was like, wow, he gets it. He gets it that he doesn't get it. But he was being real. And that was validating.
Yeah.
And so let's see, I know we're almost at a halfway mark. Should we take a quick break right now? Is now
probably a good idea. Yeah.
Is now a good time for, okay, how long of a break do we want to take?
I think we could do maybe, 10 minutes, somewhere in there.
Okay. Yep.
Perfect.
Let's do a 10-minute break, and let's be back at, it'll be 3:25 my time, whatever it is for you guys.
Thank you.
Yep. Are we all back? We ready to get started? Yeah, okay. Okay, so the first segment of the training was basically an intro to the model, an abbreviated intro. But at least I presented those 5 major skill sets. And what I'd like to do in this next segment is just talk a little bit more about each of those as time allows. First and foremost, we will talk about mindfulness. It's probably not surprising that we'll talk about that first because that's foundational to everything else in DBT. So if you think about it, how in the world are you going to change how someone thinks if they don't even know what they're thinking? Or how are you going to help them regulate their emotions if they have no idea what their emotions are? Or how are you going to help someone deal with their triggers and stressors and reactions if they don't even know what those things are? So that's why mindfulness is foundational in DBT. This is probably my best definition of mindfulness I've come across. And I love this definition because it is very simple and succinct. So mindfulness is all about learning to pay attention, but for a specific purpose, right? And it's not randomly paying attention. We all randomly pay attention when we have to or when it's too late. But this is learning to pay attention on purpose ahead of time. And doing this for a specific purpose really is extremely important if you're going to help a client buy into this concept. If a client does not understand the purpose of mindfulness training, they're not going to do it. So you really want to help your clients understand that mindfulness will give them insight not only into the symptoms of their disorder, but will also help them achieve their own life goals, right? If they can't see those two things, how mindfulness is going to help them with their disorder or their own life goals, they're probably not going to do it. So paying attention for a specific purpose, but specifically in the present. So I'm sure you've noticed we don't have to train clients to focus more on the future or focus more on the past. right? Our brain already defaults to either the future or the past, all on its own. That doesn't require any special training. So does that mean the past is important or the future isn't important? Of course not, right? We'll talk about that in a little bit. Of course they're important. But here's the deal. We don't have to practice those things. That comes too naturally to us, right? In fact, if, as we already know, people that focus too much on the future tend to experience anxiety, whereas people who focus too much on the past tend to experience depression, right? So we're specifically training people to focus on the present moment, but in doing so without judging. And this is the kicker here, because if you think about it, paying attention for purpose in the present is simply what we call concentration in our culture. But this whole idea of mindfulness is more than just concentrating. It's concentrating without judging. And here's why this is so important, right? As soon as we're focused in the moment on something, but then all we're doing is paying attention to all of our commentary about what's going on, then we're actually focusing more on our internal commentary than what's actually going on, in which case we're not being truly mindful. So therefore, mindfulness basically involves these two key concepts of awareness and acceptance both, right? A lot of times in our culture, we make mindfulness synonymous with awareness, right? Which just goes to show we don't truly get mindfulness, because it's not just the awareness. It's awareness and awareness of the moment in conjunction with acceptance of the moment. So like I mentioned earlier, right, of course, the future and the past are also important, but here's the deal. Can we better plan for the future only by worrying about the future? No, we'll actually become less prepared for the future if that's all we do is worry about the future. Or can we heal about the past only by obsessing about the past? No, that will actually make the past even worse for us. But what if instead we can help our clients learn to be grounded in the present, right? Once our clients are grounded in the present, now they can better plan for the future, which will lower their anxiety, which will help them be more grounded in the present, which will help them better plan for the future, etc. Or if we can help our clients be grounded in the present, they will now feel a lot safer to deal with traumas from the past. And the more they feel safe, the more they'll be grounded in the present, in which case, the more they can process the past, the more they're freed from their past, the more they're grounded in the present, right? That's why this idea of mindfulness is so important in psychotherapy, right? So mindfulness, like I mentioned, basically boils down to these two themes, awareness and acceptance both. So that's what we're teaching our clients. And there is indeed decades of research which suggests that the more we can help our clients become mindful, the more their awareness increases, the more their acceptance increases, and their quality of life increases. And this applies to any symptom you can think of, right? Any physiological disorder, any psychological disorder. If we can help our clients be more aware even of the symptoms themselves, and not only that, but more accepting of the symptoms themselves, then guess what? Symptoms actually start to get better, right? And I'm not saying mindfulness replaces, every single advancement in modern medicine. I'm not saying that for a second. But what I am saying is mindfulness is a very powerful tool. And that doesn't only apply to whatever clinical disorder our clients are suffering. But the more they can become aware and accepting of life in general, right, the better life in general starts to get. So DBT has this concept of expanding awareness. So when we're teaching clients mindfulness, it usually makes the most sense to first teach them mindfulness of their actual physical bodies. Why is that? Well, if you think about it, where are the five senses located? In your body. So if you're not even mindful of your own body, how in the world do you plan on being mindful of anything else? right? Basically, our body is the mindfulness tool. We need to be mindful of other things. And if you're not even mindful of the mindfulness tool, you're not going to be very mindful, period. And then once we can help our clients be more mindful of their physical experiences, from there, we help our clients be more mindful of their psychological experiences, right? Thoughts, feelings, memories, etc. And then from there, we can help our clients be more mindful of everything else in their life, right? Their relationships, their environments, their behaviors, etc. Okay, so these are just very practical ways of teaching mindfulness of the body. And there's obviously hundreds of ways of learning and practicing mindfulness. So I'm not going to give you specific examples here, but we can help our clients be more mindful of their body by teaching them breathing exercises or helping them become more attuned to their muscles through like progressive muscle relaxation, for example, more mindful of different movements such as walking or sitting or running or skating or dancing. More mindful, we can help our clients be more mindful of each of the 5 senses and sensations, right? Such as temperature or pressure. From there, we can help our clients be more mindful of what's going on psychologically in their heads, right? So here are just 5 examples of that. We can teach clients to be more mindful of thoughts, feelings, memories, urges, triggers, etc. And here's one of the classic ways of teaching mindfulness of what's going on in your actual mind. So what you do is you help clients learn to visualize their mind as if it's a river, and then everything that's going on in their mind is like a little boat floating down that river, right? So what we're teaching our clients to do is to also learn to visualize themselves as sitting on the bank of that river, and what they're simply doing is noticing all of these little boats float by. So, you know, different thoughts and memories, maybe urges, emotions, etc. Right? And maybe even helping our clients learn to describe each of those boats as they float by. But then what we also train our clients to do is just literally, you know, sit with all of those thoughts, feelings, emotions, right? Just stay on the bank of the river. Don't jump in the river, right? Don't get on those boats. And then, like I mentioned, once we help our clients be more mindful of what's going on with them, both physically and psychologically, now we can help them be more mindful of everything else in life. So you probably noticed a little bit of my OCD. I've had 5 different examples for each of these. But my purpose in these 5 examples was to demonstrate that anything can be turned into mindfulness practice, anything. So mindfulness practice could range from ordinary activities to something that maybe is deeply transcendental or meditative or spiritual, in other words. But it doesn't have to be, right? Mindfulness training could be learning to pay attention to washing dishes, walking your dog, brushing your teeth, taking a shower, driving your car on your commute, anything. We can teach our clients to be mindful of things that are pleasant or unpleasant, right? A lot of times our inclination is to teach mindfulness of things that our clients really like. And that's certainly a really good starting point, right? Like we want our clients to better appreciate all of the beauty that is in life, no matter how difficult life can become. But sometimes we forget to teach our clients mindfulness of all of the ugly in life, right? So emotions we don't like, or harsh thoughts we don't like, or sensations we don't like, or people we don't like. But here's the deal. If we can't help our clients be mindful of those experiences, then they're simply going to default to their ineffective coping strategies, right? So we also need to teach them to be mindful of things that they don't like. And we can even teach our clients to be mindful of things that don't even exist at all, right? That's where guided imagery comes in, right? So in other words, literally anything can be a mindfulness exercise. Doesn't even have to exist in real life. And once I have taught client basic mindfulness, I love to follow up with these questions. Because once again, if a client can't understand why they're doing this in the first place, they're probably not going to stay invested in the process. So once I've taught a client mindfulness, and from session to session as we review how that's going, I'll follow up with these questions. So what did you notice when last time you did mindfulness? How was this experience different from how you normally do this activity? And then 3 and 4 is kind of where the rubber hits the road. How does what you learned relate to your symptoms? And how does what you learned relate to your own personal life goals? Okay, so let me give you a practical example of what I mean by these follow-up questions. So I'll just use a fairly recent client I had that had panic attacks. And they just kind of came out of nowhere, and they were really compromising his professional life as well as his personal life. But there was something he really liked to do to relax, and that was ride his bicycle. So I said, perfect, we're going to turn that into a mindfulness exercise. So I had him practice mindfulness for 10 minutes each time he rode his bike. So when I followed up, I asked, so what did you notice? He said, well, last time I rode my bike mindfully, I noticed I started sweating. I noticed my legs started to clamp up a little bit. I noticed some, various aches and pains and cramps. My heart was beating faster. I said, okay, those were really good observations. Then I followed up with, well, how is this experience different from how you normally do this activity? Normally I just ride my bike and I don't even know what's saying things. Okay. So, your body is sending you all these signals, but you don't even notice them. Okay. But then I followed up with, well, how does what you learned relate to your symptoms? And this is what he told me. And this was the whole point of the mindfulness exercise. I wanted him to get to this realization. It's like, oh, when I have my panic attacks, I have all of those same things when I'm riding my bike, right? I start to sweat. My heart starts to pound. Maybe I'm feeling some cramps. I said, interesting. But you didn't have a panic attack when you rode your bike, did you? He said, no. I said, well, why not? He said, because I knew I was just riding my bike. I said, so, oh, interesting. So you can have these same exact physical symptoms and not have a panic attack. Huh. And then we talked about, well, how does what you learned relate to your own personal life goals? Well, okay, so if he can have these physical symptoms and recognize them and not have a panic attack, right, that will be much less disruptive to some of his professional and personal goals he had. Okay, so this was an example of taking a simple mindfulness exercise, but using it actually to treat panic disorder. And really, with this, the only tool I was using was mindfulness training. But if he couldn't connect, the 10 minutes of mindfulness work on his bike to his disorder, he would have seen no point in doing this. Okay, this is a really practical acronym that I really like, that kind of breaks down mindfulness step by step and makes this much more accessible to our clients kind of in bite-sized chunks, because it kind of walks them through this mindfulness process. So this acronym is not from DBT, but it's a really good summary of DBT concepts. So when you're helping a client learn to be more mindful, you can teach them to do these 4 things. So first of all, learn to in this case, let's apply this to emotions. And actually, let's use anger, because this is how I apply this particular acronym in my own personal life. So what I would do is I would help a client learn to recognize that anger where it's coming and when it's coming, and especially learn to recognize where it is in their body, right? So maybe, oh, my hands start to clench, or my jaw starts to clench, or maybe my heart starts to pound. Okay, good. That's good recognition. The next step is to learn to allow all of those emotions and sensations. You don't want to fight them, right? Because the more you fight them, the more what happens to the anger. So for example, if I'm angry, but in my mind I have this judgmental posture, and I start to engage in all kinds of, negative self-talk, such as, oh my goodness, this is so stupid. I should not be upset about this. Why am I such a wimp? I should just get over this. Okay, what did I just do to my anger? Right? I amplified it. And if I didn't amplify the anger, I at least added lots of other negative emotions to the mix. So learning to allow the anger is, right, part of mindfulness. And then instead of fighting it or judging it, I'm going to investigate it, right? In other words, I'm going to be curious about the anger, not judgmental of it. And that will literally trigger a completely different response in your brain, right, at the neurological level. So I wonder why I am so upset about this today when I wasn't yesterday, right? That's just curiosity. That's not trying to be judgmental. And then from there, teach your client to engage in some kind of self-care, some kind of nurture. Maybe do some deep breathing, maybe go for a walk, maybe do some other sort of self-soothing skill. Okay, so in other words, if you can teach your clients this RAIN acronym, they actually now have the nuts and bolts of mindfulness, and not just mindfulness at an abstract level, at a deeply practical level. This is what mindfulness looks like in real everyday life. This is how you apply it. Okay, so we'll talk about one more mindfulness skill, and then we'll move on to some of the other skill sets. This is quintessential DBT right here. So DBT has this idea of a thinking mind and a feeling mind. And actually an original, and still the current DBT lingo, the thinking mind is actually called the reason mind or the rational mind. And the reason I don't like that phraseology is because what does that imply about the feeling mind, the emotion mind, right? That is not reasonable, or it's not rational. And that's actually feeds into the bias we have in our culture of overvaluing the cognitive part of our brain and devaluing the rest. Because as we know, our thoughts can also be very irrational and very unreasonable. So that's why I don't like calling the thinking part of the brain the rational mind or the reason mind. It's simply the thinking mind. Just like, can our emotions be disproportionate to a situation? For sure. Well, so can our thoughts. So really, what we mean by the thinking mind is the part of our brain that communicates with words. When you think about it, that is a huge gift we have as humans, that we can process information linguistically. It's because of language that we have culture, and we have civilization, and we have psychobabble, etc. So it's an amazing thing we have. But here's the deal. Most of our brain does not process verbally. So in our cultures, by overvaluing the thinking mind, we're actually putting all of our eggs in a very small basket. The rest of our brain communicates non-verbally. And that's actually also a huge gift. If you think about it this way, babies literally would not even survive if they did not have emotions, because that's their only way to communicate. And as babies mature, become toddlers, and eventually learn language, they have an additional way to communicate now through the thinking mind, but we never lose the need to communicate non-verbally. And if you don't believe me with this point, just think of the last time someone said something to you with their words, but their body language completely contradicted what they said. What did you believe? Right? We instinctively believe what someone communicates emotionally over what they communicate verbally. Right? It just goes to show that we still need this feeling mind. And I would actually make the point that we use the feeling mind and need the feeling mind much more than we need the thinking mind. But both are very valuable. So the value of the thinking mind is it communicates verbally, but the value of the feeling mind is it communicates non-verbally. But because we have constant verbal and non-verbal messages, sometimes they don't completely agree. that's why we need this wise mind, right? This wise mind is not, a part of the wise mind is the fact that it's the convergence, it's the overlap of thinking mind and feeling mind, right? So in other words, we're using, the whole mind at once. Think of bilateral stimulation from EMDR. That'd be an example of the wise mind. But the wise mind is much more than just the overlap of both. The wise mind, think of the wise mind as, it's kind of like, it's the part of our mind that observes and supervises the rest of the mind. It's kind of like the mind behind the mind. And this is what makes us very uniquely human, that we have this ability, right? So it's no wonder that throughout, millennia, philosophers, theologians, poets, psychologists have come up with terms such as the soul, the spirit, the conscience, the intuition. All of those terms work, right? Those are all what we can consider the wise mind. And the wise mind has many important functions. So one function of the wise mind is to be mindful of what's going on in the mind. So it notices what we're thinking and feeling. But the wise mind also has a regulatory function, right? We might be overthinking or underthinking or overfeeling or underfeeling. The wise mind will pick up on that and it will balance it out. So if you think about it, the wise mind knows how to be dialectical because it can take our verbal messages and our nonverbal messages, and which sometimes are contradictory. Sometimes, a lot of times they're not, but sometimes they are. And it can work with both, right? It can synthesize them, reconcile them. So keep that in mind. The wise mind knows how to be dialectical. But furthermore, the wise mind also knows how to make good decisions. So a wise mind will consider all factors. So it'll consult with the thinking mind, and it'll consult with the feeling mind, and then make a decision. So sometimes the wise mind might decide to side with the thinking mind. There's no problem with that, as long as that decision is coming from the wise mind. Or sometimes the wise mind might decide to go with the feeling mind, right? There's no problem with that, as long as that's a wise mind decision. The wise mind might also compromise between thinking mind and feeling mind, or it might come up with something completely novel. Because the wise mind it's very wise, it's very intuitive, it's very intelligent. And the reason for that is because the wise mind is not only tapping into the thinking mind and feeling mind, it's also tapping into other sources of information, right? Especially past life experience. So the wise mind might decide, might say, you know what, this is what I'm thinking right now, and this is what I'm feeling. But based on how this situation turned out the last 20 times, this is what I'm going to be doing.
Dr. Reutter, could I ask a question really quick?
Yeah, please.
Just curious about what your thoughts are about. So would you say that we've talked a little bit about verbal versus nonverbal? In terms of brain, the ways our brain kind of processes and expresses information, would you characterize wise mind as more of a verbal or a nonverbal process?
Yes, both. So think of the thinking mind as prefrontal cortex. Think of the feeling mind as the limbic system. Think of the wise mind as both hemispheres and all brain systems working together harmoniously. Yeah. So that's if you're looking for a neurological definition, that's the best way I would say it. So obviously this is an oversimplification, but yeah, the wise mind is verbal and nonverbal both, because it's picking up on both senses, both sources of information. So sometimes you might be able to articulate what the wise mind is communicating, and sometimes it is simply an intuition from somewhere in your body. Mm-hmm. It won't always be verbal.
Sure. Thank you.
Yep. So not only is the wise mind very dialectical, it can also find the right balance, because that's constantly what it's doing. So that's why in DBT, you're constantly referencing these three minds, and especially the wise mind. So a very typical series of questions that a DBT therapist might ask is, okay, so what is your thinking mind telling you right now? So, what are the words running through your head? What is your feeling mind telling you, right? What are your emotions right now? And now, what is your wise mind telling you to do with all this information, right? Just to help clients be more tuned in to what their different parts of the brain are communicating, but then to bring it all together and use the whole brain. So some clients will have no trouble at all understanding the difference between thinking mind and feeling mind. Other clients might struggle a little bit more. And if you think about it, that makes good sense because at least in English, we use the terms thinking and feeling interchangeably all the time. We use them synonymously. So just in everyday conversation, I'm not even referring to a clinical population. So for example, a lot of times you ask someone, what do you think about this? And they'll tell you exactly how they feel. Or you ask someone, well, how do you feel about whatever? And they'll tell you exactly what they believe, right? We use those terms synonymously. So sometimes we do need to provide some psychoeducation to help clients distinguish between the two, because in psychotherapy, we mean very different things by thoughts and feelings. So one simple analogy I've used with lots of clients, especially adolescents, is I'll ask them, what's your favorite song? And after they identify their favorite song, I ask them to tell me the lyrics of the song. And after they tell me the lyrics of the song, I usually regret having asked for the lyrics of the song. But once it's out there, I then follow up with, okay, so your song has all these words running through it. That's just like your thinking mind, right? Your thinking mind has these words running through it. That's what we mean by thoughts. They're the words running through your head. Then I ask them to describe for me the music of the song. And then describe, things like the beat and the rhythm and the harmony and all of that. And then I explain, okay, so just like your song has music running through it and not just words, well, that's exactly like your brain, right? Your brain doesn't have just words running through it. It also has these things called emotions. And just like the music sets the tone or the mood for your song, that's what your emotions do too. So, then I ask them to have the clients think of what the song would be like with just the words. And, just the words alone obviously convey a lot of information, but it's not the full song. Or then I have the client think of the song without the words, just the music. And obviously the music alone too is also doing something to you, but the song is much more complete with both the words and the music, right? With a song, you listen to both without even realizing you're listening to both because they're so intertwined. So that's what we want to help clients do with their thinking mind and feeling mind too. There's a lot more I can say about this, but that should give us a pretty good idea. So basically, like I mentioned, the wise mind is doing this balancing act. It's helping us balance between thoughts and feelings, between doing and being, acceptance and change, mindfulness and mindlessness. Right? We could go on and on and on. The wise mind is constantly doing this balancing act. And actually, that's what DBT is all about. It's helping our clients learn to be more balanced, find the middle ground with all of the extremes in their life. And if you think about it, especially someone that's been traumatized, they are forced to the extremes because trauma is an extreme situation. So as we know, our clients that have been traumatized, they have all of these competing tendencies at the same time, right? Sometimes they overfeel, sometimes they're just completely numb. Sometimes they overthink, right? They just obsess and ruminate. Sometimes they're just not thinking enough, right? They're too impulsive, right? Sometimes they completely overreact to something, and sometimes they're just paralyzed. They don't even react at all. Sometimes they are much too needy and clingy, dependent on other people. And sometimes they burn bridges that they can't afford to burn because they want to show everyone how independent they are, right? So once again, the wise mind knows how to find the right middle ground, the right balance. So that's why when I'm working with clients, I actually prefer to think of DBT as developing balanced therapy. That's really what it is. If you strip away all the technicality of dialectical behavioral therapy, which is, not how normal people talk. What does that even mean? Well, dialectical behavioral therapy literally means finding the right balance. So in my opinion, this is a better use of those letters, at least when we're working with our clients.
I have a question.
Yes.
So if you were to say, like, it's kind of the bottom, the most important goal of DBT to walk away with to help your client, is wise mind the ultimate goal of DBT?
Yeah, helping our clients get into their wise minds. Yep.
Okay.
So, once again, clients are gonna need that wise mind even to learn the rest of DBT. Because, how are you gonna regulate your thinking if you don't know what your thoughts are? Right? You have to be in the wise mind to recognize your thoughts and neutralize them. Same thing with the feeling mind. How are you gonna help clients regulate their emotions if they're not in a wise mind to even know what they are? Right? And you're gonna have to be much better at managing your thoughts and your feelings to be able to manage other aspects of your life too. Yes, that's a really good summary statement. Okay, so another skill set is distress tolerance. I really like these two kind of lay definitions. Distress tolerance is all about helping clients survive the moment without making it worse. So in other words, distress tolerance in and of itself is not about helping clients fix things or make things better. Think of this as harm reduction. We're just helping our clients contain so that they don't make things even worse. And the reason that we need to start there is because we can't help clients make things better while they're actively making things worse. And that's what they're doing with their maladaptive coping. They're taking a bad situation and making it even worse. So distress tolerance is kind of, it's short term. It's not long term. Other aspects of DBT are long term. This is just short term coping in the moment. Another way of thinking of distress tolerance is helping our clients turn unbearable pain into bearable pain. In other words, we're not helping our clients take away their pain. We're helping them actually sit with it and deal with it, because their maladaptive coping strategies are actually attempts to avoid the pain. But those maladaptive coping strategies actually cause even more pain down the road, or sometimes even more right in the moment. Okay, so if you think about it, there's actually lots of overlap between mindfulness and distress tolerance. So for example, could you use breathing as strictly a mindfulness exercise? Yes, you could. Could you also use breathing as a relaxation or self-soothing exercise? Yes, you could. Right? So basically think of it this way: distress tolerance is applied mindfulness, right? You have to have some level of mindfulness even to do distress tolerance. So basically distress tolerance is helping our clients take any of these types of coping strategies that make things even worse and cause even more of a crisis orientation, right? Replace all of that with coping that's going to be more effective. And DBT has many ways of going about this, right? Distress tolerance is actually overwhelming because there's dozens and dozens of these different kinds of skills. So what I've done is I've broken all of the different DBT distress tolerance skills into these three main categories. Some distress tolerance skills are all about coping in your mind, right? So I'm calling those coping mindsets. Some are all about using your body itself to cope. So I call those coping postures. And the majority of DBT distress tolerance is all about specific things you can do. So those are what I call coping skills. And unfortunately, in this training, I think we're only going to probably have time to talk about just one of tons and tons of different coping skills. I mean, tons and tons of different distress tolerance skills. So I'm going to use something that actually comes from a coping mindset called radical acceptance. And this is by far the most abstract of all DBT concepts, especially in distress tolerance. Everything else is much more practical, hands-on, concrete. This one is a tough one. It's tough even for us, and it's going to be even more difficult for our clients because this is kind of philosophical. So I'm going to start off with a very basic lay definition, and we'll expand from there. So at its core, radical acceptance is all about seeing things just, as they are, right? Not better, not worse, not more, not less. So think about it. Someone with borderline, what's their tendency? They see things at the extreme. So people with borderline tend to make things either much better than they are or much worse, right? So radical acceptance is all about learning to see reality just as it is. But part of what makes radical acceptance so difficult to explain is Marshall Linehan is actually using this term acceptance quite differently than how we normally use it in everyday English, right? And this can cause all kinds of confusion. So when we normally use the term acceptance, what we usually are referring to accepting something that you actually like or agree with, right? If I give you a gift and you accept it, that means you like it and you appreciate it. Or if I share some kind of political opinion with you and you say, yeah, I can accept that, right? You're implying that you agree with me. Okay, radical acceptance is actually the complete opposite of that. Radical acceptance by definition means that you accept something you emphatically do not like. By definition, that's what makes it radical. So this is where this gets a little bit confusing for our clients. Radical acceptance, however, does not mean that you approve of or agree with it, right? It simply means that you are going to acknowledge it and embrace it anyway. So radical acceptance does not mean you like something, but it does mean that you will choose to deal with it. So if your clients are struggling with this concept so far, a simple analogy I use is, well, is it possible to hug someone that you don't like, right? Is that physically possible, right? It is. Happens at every family reunion, right? We embrace people that we don't necessarily like. So if your client can visualize that at a practical level, concrete level, then you can explain, well, it's also possible to emotionally embrace something you don't like as well, right? It's possible. It's not easy, but it's possible. Okay, so when you're explaining radical acceptance to clients, you also want to make sure that you explain that radical acceptance is actually the complete opposite of denial, right? Because sometimes when we use the word accept in normal everyday English, what we mean is, yeah, we're just going to condone it or look the other way or let it slide. That's actually that's not what radical acceptance is. Radical acceptance is actually helping our client strip away their defense mechanisms, which can be a really painful process, because we're helping clients see things as they really are, not through the filters of all of these defense mechanisms. And it's also important to explain that radical acceptance is active, not passive. So, especially if you're working with different cultures. So some cultures, I have Hispanic culture in mind right now, do have this idea of just like fatalism, of just being resigned to fate or destiny because there's nothing I can do about it anyway. That's actually not quite what radical acceptance is, right? It's not a passive process. It is active, right? If there's something to be done, by all means, do it. But radical acceptance starts with what is, right? We can't change reality until we know what reality is, until we've embraced it. So you'll see these two equations kicked around a lot in DBT circles, these word equations. So the first one says pain plus radical acceptance equals healing. So in other words, if there's something painful in your life, but you accept it, you acknowledge it, you embrace it, well, actually, you are now on the path towards healing. And you can use all kinds of physical analogies to help your clients understand this, right? If there's something wrong with your body, but you acknowledge that there's a problem, well, now you can go to the doctor. Now you can, get it checked out. Now you can do something about it. On the other hand, pain without radical acceptance equals suffering. So if there's something painful in your life, but you just can't deal with it, you're in denial about it, or you're minimizing it, or you're making it even worse than it is, or whatever, regardless of what you're doing with that pain, if you're not fully accepting it, that pain is going to tend to get worse. So once again, DBT kind of has its own unique suffering it's its own unique definition here. What DBT means by suffering is it's referring to pain that keeps escalating and compounding when there is something we could have done about it. And once again, you can use medical analogies or other analogies to explain this, right? If there's something wrong with your body and you just completely ignore it, chances are it's going to get worse and worse. So that's why pain is required, but suffering is optional. Okay, so remember, DBT has its own unique definition for suffering here. What this does not mean is, anyone that has suffered in human history, well, that was completely on them. Why did they sign up for that? That's not what it means. It's referring, once again, to something painful that we haven't dealt with, and that's why it got worse, right? So pain is required. Why? Because it's part of both of those equations, right? Pain's a given. Life is just painful, period. But suffering is optional. What that means is when we don't deal with something that's painful, yes, it probably will get worse. So another phrase you'll hear a lot is radical acceptance is the first step out of hell, right? You have to know you're in hell in order to get out. So once again, we can see how radical acceptance is the opposite of denial, but it's also active. It's not passive. It's not, oh, I'm in hell, I guess this is the way it'll always be. No, that's not radical acceptance. It's the energy, it's the momentum to take that first step. And also part of what makes radical acceptance difficult is it might play out differently based on the life scenario that needs to be radically accepted. So some of our clients need to radically accept things from the past because nothing from the past can be changed. Sometimes our clients need to radically accept something in the present because there are some current ongoing situations that also can't be changed. But then there's also things that our clients need to accept in their current lives precisely because they can be changed. Right? So, maybe you cannot change the fact that you're wired for an addiction, right? Maybe that's something you need to radically accept, but maybe you can change with help some of your lifestyle choices. Do you see how both require radical acceptance? One, I'm wired this way and I can't change how I'm wired, but yeah, I can change who I hang around or the places I go, right? Or the behaviors I engage in. So I'm not here to suggest for a second that radical acceptance is easy, because it's not. It is really hard. But the problem is not radically accepting is even harder. So you will meet clients that are struggling more because of their inability to accept something than the actual thing, right? You'll meet clients, for example, that struggle more from their inability to accept something from the past than what actually happened in the past, because what happened in the past stopped and started, but their inability to accept is ongoing. Or you'll meet clients that are struggling more with they're suffering more because of their inability to accept a current ongoing situation than the situation itself. Or you'll meet clients who are suffering precisely because they could change something in the present, but they haven't radically accepted it yet. I love this quote from Viktor Frankl: "When we are no longer able to change the situation, we are challenged to change ourselves." So Viktor Frankl was a psychiatrist that survived World War II, including multiple concentration camps, including Auschwitz and other concentration camps. And he was absolutely a source of inspiration for Marshall Linehan. In fact, she references him in her manual. So, why is this whole idea of accepting reality so important, right? Why don't we just cling to our defense mechanisms? Well, here's why. And Marshall Linehan explains all of this in her manual. Well, first of all, pain can't be avoided, right? It's just a fact of life. In fact, the more we do try to avoid pain, the worse it gets. And just because we deny reality doesn't mean we've changed anything. It's still the same reality, whether we accept it or not. But also, if we do want to change reality, we first have to accept it. And accepting may increase sadness at first, but then it leads to peace and freedom. right? So the more we accept something, the more we are in tune to what reality really is. And the more we will realize, wow, things are even worse than I thought. That could happen. But the more we realize the facts as they are, the more we can deal with those facts. And then Marshall Han says this is a direct quote from her manual. It doesn't sound too encouraging. The path out of hell is through misery. But what she's doing here is she's normalizing how difficult the healing process is, right? Just because you realize you're in hell and you take your first step out of hell doesn't mean you're now in paradise. No, the healing process can still be really difficult. So, while we're on this slide, maybe we can just pause and just briefly talk about current events. If anyone would like to share how we can then apply this idea of radical acceptance to any of the current events we've been experiencing. This could be the pandemic. It could be, mass protests because of George Floyd. Would anyone like to speak to this idea of radical acceptance? Facing the facts as they are, being active, not passive, just ignoring pain doesn't change anything. Does anyone want to speak to any of that?
This is April. Something I'm thinking about is sort of this refusal on the part of white folks in particular to sort of accept the reality of white privilege and to accept the reality of white supremacy and anti-Black racism, right? Like, I think that this is a reality that a lot of folks are in denial about, and the idea of giving up privileges or the notion of fighting for a different kind of world can feel really scary, and that can feel like kind of pain. And so for me, just sort of like I feel like I could apply this idea of radical acceptance to like literally acknowledging that we live in a white supremacist society. We live under this constant reality of anti-Black racism, of oppression, of systemic marginalization, and the only way to change that is to acknowledge that it's happening, to embrace, not in terms of accepting, of being okay with it, but embrace like this is real, this is happening, and the only way to get out of it is through it.
Yeah. Thank you for sharing that. Would anyone else like to speak to that? No pressure or obligation. I just want to give anyone an opportunity to speak up if you would like to. Yeah, so, how we normally use the word accept in English, if we applied that kind of acceptance, obviously would be completely inappropriate, right? Because how we a lot of times, like I mentioned earlier, use the term accept is to condone, look the other way, just sweep it under the rug. And that's clearly not what we mean by radical acceptance. It's realizing just how bad something really is, which then puts us in a position to do something about it. So, back at a clinical level, these are some sure signs of when our clients probably need to do some radical acceptance. So basically, if there's anything that's relevant to treatment that they're just constantly either avoiding or blaming or making excuses or lying about, etc. Basically, overuse of any defense mechanism, that's probably precisely something they need to learn to radically accept. Okay. And the reason I chose radical acceptance for distress tolerance is because if clients don't have a firm understanding of radical acceptance, it's going to be difficult for them to learn and implement any of the other practical, concrete coping skills. Have you ever met the client that no matter what skill you suggested or recommended, they said, yeah, that one doesn't work for me, or yeah, I tried that once. So that's why radical acceptance a lot of times is also foundational in DBT work. But I don't want you to think that distress tolerance is only philosophical. It's also very hands-on, very practical, very concrete, but fortunately, we don't have time to talk about any of that. So let's move on to another skill set. This is emotion regulation. And this is different than what you would normally think of emotion regulation as. So once again, just get used to Marshall and having your own unique definition for everything. Emotion regulation in DBT is actually not about coping with your emotions in the moment. That's more distress tolerance type of stuff. Emotion regulation from a DBT perspective is all about helping our clients have a complete lifestyle change that will foster healthier emotionality. So remember, mindfulness and distress tolerance skills are basically acceptance skills, right? Helping our clients accept what is. The rest of DBT is all about long-term change. So something we have to do with our clients is provide basic psychoeducation on even what emotions are in the first place and why we have them and why we need them and what they do for us. So remember, we have the thinking part of our brain that communicates, motivates, and influences with words. But we also have the feeling part of our brain that does the same thing without words. If you think about it, this is exactly what our emotions do for us, right? They communicate, they motivate, and influence not only ourselves, but other people. And they do it without words. That's an amazing thing, right? It just goes to show, once again, why we need both the thinking part and the feeling part of our brain. Because there's so much in life for which words are not adequate, right? That's why we need emotions to help us communicate, motivate, influence. And so what I have done to make DBT not only more culturally sensitive, but also more user-friendly with our traumatized clients is I've created this garden analogy. So this is not coming from Marshall Linehan or her manual. This is my attempt to make DBT, like I said, both more culturally sensitive and also more trauma accessible, more trauma informed, I should say. So DBT does have these 6 different interventions to help our clients have healthier emotionalities. But I don't necessarily like how DBT presents it. So like I mentioned earlier, I mean, you'll read workbooks and texts from prominent DBT therapists that literally refer to emotion regulation as controlling emotions. You'll see that over and over and over and over again. I do not like that phrase whatsoever. So if you think about it this way, if you had a garden of flowers, would it make any sense to try to control those flowers? Or to shame those flowers or judge those flowers or guilt trip those flowers or yell and scream at those flowers? Obviously not, right? And none of those would be DBT interventions, obviously, but DBT does use this phrase of control emotions. Well, that wouldn't work with flowers. Doesn't work with most things in life. What does that garden of flowers need, right? It needs you to actually tend to them, to take care of them, right? To water them, to fertilize them. You need to cultivate that garden, not control it. So that's kind of the paradigm shift that I am trying to encourage others to use too. So what I've done is I've taken all 6 of these DBT interventions, but what I've done is I've kind of reframed them in terms of this ongoing garden analogy. So we're just going to hit on a few of these. But part of what DBT does is it teaches clients to take better care of their bodies. And you might think, okay, but what does this have to do with emotion regulation? Well, it has everything to do with emotion regulation. Because since there's such an obvious mind-body connection, if your body is completely out of whack, so will your emotions be out of whack, right? There's no way around it. So part of DBT is helping our clients learn what's going on in their bodies and also then to figure out plans to deal with whatever's going on in their bodies if it's problematic. So basically we provide basic psychoeducation with our clients to help them figure out, what are some untreated symptoms in your body? What does your daily exercise routine look like, or in many cases not look like at all? What are your basic eating habits? What substances are going in your body, right? What is your basic sleep hygiene? So I don't know about you guys, but I know in my case, if just one of those things is slightly out of whack, I'm out of whack, right? I'm a wimp. It does not take me much to get out of whack, right? If I just miss a meal, if I go a few weeks without my 20-mile bike ride like I did this morning, I am out of whack. But you think about our clients, there's complete chaos probably in each of these domains. And we can't possibly help them have healthier, more balanced emotionality when their own bodies are in complete chaos. Right? So once again, we provide psychoeducation to help stabilize each of these domains as kind of foundational. And then from there, we can help them deal with other lifestyle choices. And I like this analogy of, we're going to plant some seeds, right? This is a very gentle way of helping them learn to take better care of themselves. Okay, so another classic DBT skill for emotion regulation is acting opposite. And the reason this is so important is because when our clients have some pretty intense, overwhelming emotions, a lot of times their urge is to do something destructive with that emotionality instead of something constructive. So what we want to do is help our clients identify trigger emotions. So we don't want to call them negative emotions or problem emotions, because that reinforces the message that there's certain emotions that we shouldn't have or they're bad. The only reason that certain emotions are triggering is because they reach a high level and then we're fearful of that level. So it's not the emotion itself that's problematic. You want to make that crystal clear. What's problematic is the urge, right? So sometimes when our emotions reach intense levels, our urge is to do something, like I mentioned, destructive. And the problem with that is the more we act on that urge, the more we amplify our emotions, which then further exacerbates the urge, and then it's just round and round and round. So I call that the stupid cycle. That's not DBT lingo. And I am obviously not calling clients stupid. We all recognize this pattern where we react to a strong emotion with an urge that only makes things worse. And when we do that, we're clearly not using our wise mind, right? So the only way out of this vicious cycle is to help our clients do the opposite of that urge, right? So on paper, this is, a very easy skill. Just do the opposite of what you feel like doing. So it's easy to understand, but this is the hardest skill in the world to implement. Why is that? Because nobody likes to do what they don't like to do, obviously, by definition, right? So actually doing the opposite of your urge is really hard work. And it's going to require lots of other DBT skills and supports to pull that off. So there's different ways we can help clients act opposite. We can help them, literally do the opposite of what they feel like doing. We can help them act opposite with their body posture, right? So if they feel like clenching up, then maybe learn to relax your body. You can act opposite with body chemistry. So if you notice your temperature spiking, right, do something to literally physically cool you down. That's something I do all the time. It works really well for me. You can act opposite with imagery. So just visualize the opposite, even if you don't actually do it, or act opposite with words, right? So say the opposite of what you feel like saying. And then what you do is you help clients come up with basically an acting opposite plan. So in the first column, you help them identify their trigger emotions. So it might be depression or anxiety, anger. From there, the problem urges. So each of the urges that go along with those emotions, which when acted on, make things even worse, right? Not every urge we have is a problem urge. It's only a problem urge if it's destructive or it's going to make things even worse. And then from there, help the client come up with something that's completely the opposite. So let me just use depression really quickly as an example. So that's a pretty common trigger emotion many of your clients might face. So depression would go in the first column. From there, you would help the client identify the urges associated with depression. So when you feel depressed, what do you feel like doing? So it might be staying in bed all day. It might be isolating. It might be overeating. It might be oversleeping. It might be some kind of self-harm, right? It might be indiscriminate sex. It might be drugs. And then from there, what you do is you help the client recognize the connection between those first two columns. So you want them to realize, okay, so the more you feel depressed, the more you feel like doing these things. And for some clients that might not necessarily be an aha moment. It might be more like a duh moment, like duh, of course I feel like doing those things when I feel depressed. But not all clients are connecting the dots there. So you don't want to necessarily take that for granted. But then what you really want to do is also explain how the more you follow those urges, the more you're going to feel depressed, right? So that's exactly why untreated depression can last so long. It's because the disorder causes the symptoms, but the symptoms cause the disorder, right? And that's not, that doesn't only apply to depression. That applies to many disorders. That's why mental health is so persistent, right? Because once again, disorder causes symptoms, but symptoms also cause a disorder. And you want clients to really understand that. So, Amy, let's just do a thought experiment right now. Let's assume you weren't even depressed, but you decide that you are going to make a habit for an entire month of procrastinating, not meeting any of your obligations, avoiding all human contact. You're just going to stay in bed all day. You're only going to, get up once in a while to think about your own death and maybe drink and maybe cut and then just go back to bed. Okay, just go on and on with those kind of behaviors. Would it take a full month for you to feel depressed? Right, of course not. I know I would feel off in just probably a few hours of doing that kind of stuff. And the reason you really need clients to understand that connection between the urge and the emotion is because otherwise they're not going to see any point in acting opposite. But once you have all of these urges identified, now you can help a client identify strategies of things that they can do to pull them in the opposite direction. Right? So getting up at a certain time, going to bed at a certain time, portion control, here I'm using the word control, right? Managing your portions, balanced healthy diet, mindful eating, right? Some kind of self-soothing strategy instead of a self-harm strategy, etc. That's all the things that you want to go in the acting opposite side. And then another way we can help our clients continue to nurture this guard of emotions is teach your clients what they need to do to fertilize. So DBT teaches these ABC skills. So this is what we want clients to start doing every single day so that they start to have that lifestyle change we talked about that will support a healthier emotionality. So don't just wait for something positive to happen. Every single day, schedule something positive, right? Every single day, make sure something positive happens for you. Every single day, do something that helps you feel competent or confident, right? That's the idea behind build mastery. So develop a skill, develop a hobby, right? The idea here is to help our clients foster a sense of self-efficacy, right? Every single day, do something that you're proud of, that makes you feel like you've accomplished something. And then also, don't just wait for the next crisis to happen before you start coping. No, cope ahead of time. Every single day, start to develop a lifestyle of coping, right? So all the coping skills you've learned in distress tolerance, have a plan to do that every single day. Make that your new normal, right? Have a lifestyle of coping. That will help you become less triggered by crisis in the first place, right? Coping ahead of time has a preventative effect. But then when you are triggered, that's your cue to do even more coping. I actually added a D. So I teach clients to do A, B, C, and D. So every single day, also do something that is personally meaningful for you, right? Remember, the whole goal of DBT is to build a life worth living, right? So what are your values? And every single day, do something that's in line with those values. Okay, I could stop now and take questions. Or do you want me to present a little bit more material? Really does not matter to me either way. We only have about 10 minutes. Does anyone have any questions you want to make sure I answer?
Looks like we have 1 vote for material in the chat.
Okay.
2 votes for material in the chat.
Okay, that's fine. I can keep going.
Oh, 3 votes.
I could go all day and all night if you want me to. I'll just go for another 10 minutes or so. Okay, so obviously in dialectical behavioral therapy, we're also teaching our clients how to not just think more dialectically, but also process life more dialectically. Some good lay definitions of dialectical thinking to get us started with this topic. Basically, dialectical thinking is all about the ability to start to see things from different perspectives, right? And not just your own perspective. Realize that other people also have perspectives, and both perspectives can be valid. But also helping clients start to generate multiple perspectives all on their own, right? Learning to think about things through this angle, but also another angle too. Dialectical thinking is also the ability to learn to think more in the middle, not always at the extremes. It's also the ability to be more flexible in how you think, not so rigid. And especially the ability to change how you think when you're presented with new information. Because if you do not have the ability to process dialectically, it does not matter how much information you have, right? You still continue to see things the same way you always have. So a really simple analogy you can use with clients for them to understand this idea of dialectical thinking. You can use this imaginary candy bowl, or you can even bring in a real candy bowl. So let's assume 2 different people are both looking at this candy bowl, and one person swears head to toe that they see Twizzlers, but another person swears head to toe that they see jelly beans. Well, who's right? Right? Obviously, they're both right. So it's just a very simple visual intervention to help clients realize it is possible for 2 different people that are both very reasonable and both have, complete visual capacity. They can look at the same thing and still see different aspects. So if you can help a client understand that with the candy bowl, you can help them understand that, well, actually many things in life are just like that candy bowl, right? 2 different people can have 2 different perspectives, and both perspectives can be both completely valid at the same time. So I want to just briefly go back to original CBT because I want to show how DBT is different. So original CBT has this idea that thoughts lead to feelings and feelings lead to behavior. And CBT also has this idea that we tend to blame how we feel or react on the situation. And what CBT says is, now wait a minute, it's not necessarily the situation that's causing you to feel a certain way or react a certain way. It's really how you think about that situation. And there's obviously lots of validity to that. But where this breaks down is, what if you put your hand on a hot stove? What if that's the situation? Well, trust me, it really doesn't matter what you think about hot stoves. Doesn't matter what your core beliefs are, right? You will have a very intense emotional and physiological reaction. So CBT recognizes that, but CBT says, okay, fine, but most things in life how you think about things really does mediate your and influence your feelings and behaviors. Okay, fine. But now let's assume you've been traumatized. And let's assume you come across something that's a trauma reminder. In other words, it's a trigger for you. Well, by definition, right, just look up the DSM criteria for PTSD. By definition, you will have a very intense psychological and physiological reaction, and it's completely involuntary, to that trauma reminder. Right? In other words, it doesn't matter what you think about that trauma reminder. Right? That's where CBT is limited when you're doing trauma work. Because what's going to happen when you try to tell your clients, oh, you just need to change how you think, right, the next time you have that trigger? It's not going to work. Furthermore, that's going to be a highly invalidating message. You're basically saying it's all in your head. Okay, so CBT goes a step further, and CBT says, once you have this sequence in motion, it doesn't even matter what the situation is a lot of times, because how you think drives how you feel drives how you behave, but how you behave reinforces how you think. So, does that sequence really play out? Thoughts, feeling, behaviors? Well, of course it does. I don't think anyone's going to dispute it. But the problem is that is grossly oversimplified, because the reality is thoughts, feelings, and behaviors all influence each other constantly. And if you only have the sequence of thoughts, feelings, behaviors, you're very limited. And actually, in terms of what you can do clinically. And like I mentioned earlier, what we now know from neuroscience is feelings influence our thoughts much more than thoughts influence our feelings. So once again, if we only have that original CBT sequence, we are very limited. So DBT recognizes that all three influence all three, and therefore it doesn't matter where you intervene a lot of times. Right? Most of distress tolerance in DBT is all about you're not in your wise mind, so you can't regulate your thoughts or your feelings, so therefore just do something, right? Do something specific until you're in your wise mind, right? So that kind of turns the whole CBT sequence on its head, right? Of thoughts, feelings, behaviors. What DBT says a lot of times is just do something differently, and that will help your emotions and your behaviors, or your emotions and your thoughts. Okay, so we'll end on this. This is a very simple DBT intervention to help a client change their thinking. Because sometimes that is where you need to intervene, and DBT is completely okay with that. But DBT is going to help clients change how they think in a much different way than CBT. Remember, with CBT, if a client has a problem thought, a negative belief or whatever, what are we going to do, right? We're going to point out how it's not logical, it's not rational, there's no evidence for it, on and on and on, right? Which, once again, if we're dealing with someone with borderline, that's going to be even more invalidation. So instead of working against the grain, DBT works with their grain. Remember, someone with borderline has very binary thought patterns. Well, if you already know that, well, then work with them. Right? Work with how they're wired, not against how they're wired. So what you do is you help them come up, identify that thought, whatever thought it is. You don't need to do a ton of psychoanalysis to figure that out. Basically, whatever's coming out of their mouth is what they're thinking. And then from there, help them come up with the complete opposite, right? Remember, that's how they already process. So work with that. And usually a lot of times, people with borderline can easily come up with something that's the complete opposite. Why? Because that's how they process. But then what's really difficult for them is coming up with something more in the middle. And at first, you're going to have to coach them on that. But over time, it's even better if they can get to the point where they can come up with something in the middle. Okay, so why do we go in this order of thought, opposite, middle? Well, the whole purpose of coming up with the opposite first, before the middle, is because you need to understand, you need to know what the two extremes are, right? The two end zones, so to speak, before you know what ground you have to work with in the middle. So let me just give you a simple example of how this might work. So the original thought, maybe the client is thinking is, I am a complete failure. I'm not good at anything. Okay, the complete opposite of that would be, I am perfect. I've never made a mistake. I don't need to practice anything because I'm the master of whatever I try the first time. So obviously, is that true? No. And a lot of times you even want to exaggerate the opposite thought for effect, right? Embellish it. And the client will easily notice that the opposite thought is not true. So then you kind of have your foot in the door to explain, okay, but you're pretty convinced that the original thought was, right? But then from there, you simply go to the middle. What's something more in the middle between those two extremes? So something more in the middle might be, yeah, there's lots of things I'm not good at, but there's also some things I am. Okay, so basically, whatever they come up with in the middle is already dialectical thinking. It doesn't have to be dead center, right? We're simply helping them figure out another perspective that's not their original thought. And just because you help them come up with the middle thought doesn't mean now they completely 100% believe it. Of course not. But now at least there's some competition, right? There's another thought that's percolating in their heads. And the reason you really want the client to come up with that middle thought is because if they're the ones that said it, those words came from their head, right? So part of them does believe it, right? It's just a really simple strategy to get clients more to the middle, and it bypasses a lot of that resistance that you'll get from traditional CBT. So that's a really good ending point. We didn't get to interpersonal effectiveness. That's fine. It's basically when we take everything else we've learned to help regulate ourselves, and now we also apply those skills to dealing with other people. So if you think about it this way, you can't possibly deal with someone else's emotions if you can't deal with your own. Or you can't deal with someone else's triggers if you don't know how to deal with your own, right? So all of that other skills work is kind of preparatory to help clients now learn to deal with other people. So I'll end on that note.
Thank you very much, Dr. Reutter, for joining us today and for giving us this training.
Thank you, guys. Really appreciate the opportunity.
All right. Any other questions? Any final questions, thoughts? If anyone would like the video link to our training today or the PDF files, I'll drop my email here in the chat and you can reach out to me and I'll send them on. Well, if there's nothing else, I guess then we can adjourn for the day. Thank you again, Dr. Reutter.
Yeah, thank you guys for your participation.
Thank you, Dr. Reutter. This was awesome.
Good deal.
Thank you. Take care.
Thank you.